Welcome, Dr. Satya.
Thank you.
Pradeep, can you just alert Jitin? Can you do that?
Yeah, I'm sending him a text, Ryan.
Okay.
We are live now, Doctor.
Okay, thank you. So on behalf of the Tamil Nadu Ophthalmic Association, it gives me immense pleasure to welcome you all for this international webinar titled Glaucoma Unmasked Evidence-Based Strategies, organized as part of the World Glaucoma Week celebrations. Glaucoma continues to be one of the leading causes of irreversible blindness worldwide. What makes it particularly challenging is its silent and insidious nature, often progressing without symptoms until significant vision is lost. This is precisely why platforms like today's webinar are so important. By focusing on evidence-based strategies, we aim to bridge the gap between evolving research and everyday clinical practice, enabling ophthalmologists to diagnose earlier, treat more effectively, and ultimately preserve vision. World Glaucoma Week reminds us not only of the scientific advances in glaucoma management, but also our collective responsibility to improve awareness, strengthen screening, and ensure timely intervention for our patients. We are privileged to have with us an outstanding panel of experts who will share their knowledge, clinical insights, and practical pearls. I'm certain that today's discussion will help us unmask the complexities of glaucoma and translate evidence into better patient care. I would like to congratulate Professor Dr. Venkatesh for putting together this meaningful academic program and thank all the distinguished speakers and participants for being part of this important initiative. With that, I warmly welcome you all and wish the webinar a highly engaging and enriching session. Thank you. Just give me a couple of minutes to share the... So I would like to introduce Professor Venkatesh, who's going to be the moderator for today's program. Professor Dr. Venkatesh is the Chief Medical Officer at Aravind Eye Hospital, Pondicherry.
If I can make it full screen, maybe it will look better.
He's a great clinician, researcher, and mentor to a young team of doctors interested in innovation. He has received numerous awards and recognitions from national and international societies. He'll be receiving the Chang Crandall Humanitarian Award in the upcoming ASCRS annual meeting and the KR Data Award in the upcoming AOS meeting for strengthening opportunistic screening and managing glaucoma through innovative approaches. I'm extremely grateful to Dr. Venkatesh for putting together this program. Dr. S.R. Krishnadas, a very renowned glaucomatologist, has been serving Aravind Eye Hospital in various capacities for the past quarter of a century. He has been head of clinical services and a chief medical officer and currently serves as the director of fellowship and physician development program. He has been a visiting fellow at the Wilmer Eye Institute and Bascom Palmer Eye Institute and has been actively involved in patient care, training, and teaching of postgraduates and fellows. He has 96 peer-reviewed publications and has been a part of epidemiology study on glaucoma conducted at Aravind Eye Hospital. He has delivered several orations and papers in national and international conferences. Dr. Satyan is director of Satyan Eye Care Hospital at Coimbatore and the Glaucoma Foundation. He held the position of Chief Glaucoma Services of Aravind Eye Hospital for 15 years and performed more than 75,000 cataract, glaucoma, and other surgeries. Dr. Satyan is also working with Shankara Eye Hospital and PSG Hospital in Coimbatore as Professor of Ophthalmology. Till date, he has trained more than 150 ophthalmologists in glaucoma at national and international level, in addition to donning a hat of guide and mentor for many ophthalmologists and non-ophthalmologists. Presently, he is the president of Glaucoma Society of India. Dr. L. Vijaya headed the glaucoma department at Shankara Nethralaya for more than 20 years and trained many glaucoma specialists within the country and elsewhere. She has published 178 papers, authored 10 chapters, and delivered 180 lectures. As a principal investigator for the Chennai Glaucoma Study and Chennai Eye Disease Incidence Study, she has played a pivotal role in the understanding of glaucoma in India. She has been actively involved in various professional organizations, including serving as a president of the Glaucoma Society of India and holding positions in prestigious national and international committees such as World Glaucoma Association and Asia Pacific Glaucoma Society. Dr. S. Kavita currently heads the glaucoma department at Aravind Eye Hospital, Pondicherry, with 2 decades of experience in glaucoma. She has 95 peer-reviewed publications and 6 textbook chapters. She's one of the editors of GSI Guidelines for Glaucoma. She has received multiple prestigious awards and is actively involved in teaching, training residents, fellows, as well as in research. I'd like to ask our moderator, Professor Dr. Venkatesh, to take over from now.
Thank you, madam, for organizing this very important webinar during the World Glaucoma Week celebration. We all celebrate to create more awareness about glaucoma, not only to patients, but also to our eye care providers. And this is one way of doing it. Can you stop share, madam? So we're going to have this interesting session. We are going to have my good friend Pradeep Ramulu, who is going to give the first talk on what we should be doing in the AI world. But Pradeep has been, I know Pradeep since he was doing glaucoma fellowship at Bascom Palmer way back in 2007 and 8, after his residency in Wilmer. And he is doing a terrific work in glaucoma, which we are all now coming across through various areas. He has been also the scientific committee chair at AGS, WGC. I know at present he is the director of the Wilmer Glaucoma Division. And also he is the Sheila K. West Professor of Ophthalmology at the Wilmer Eye Institute. I can go on talking about Pradeep, but I think I have to listen to what Pradeep wants to say now. Pradeep?
Okay. Thank you, Venkatesh. Yeah, well, I really appreciate being here. Many have many long-term friends on this call, and some people who are doing even better than me in their careers, and will have go on to have all these honors and even more, I hope. So let me share my slides, and I feel like I'm setting up the next few speakers, Dr. Damji, Johannan, and Zebradast. So let's see, am I allowed to share my screen here? Are you seeing everything okay?
Yeah, it looks fine.
Yeah. Okay, great. So I'm going to talk about the role of the eye care provider in the post-AI world. And so this is a topic which is not really very heavy on data, although I'll throw a little bit in there, but really kind of give some reflections on maybe where the field is going and what our role is going to be. So these are my disclosures, including my open payment slide showing the level of support that I get from industry, which is not very high. Well, I want to thank you to my colleagues who really are going to teach me how to use AI in my practice. But I want to kind of give a broader view because I think we should always be looking at the long time frame and long horizon. And I think AI is going to really change our practice, but there's going to be things that we need to adjust to for the post-AI world as well that are also very important. This is a list that I made maybe about a year ago when I was just thinking about how AI can transform medicine. And I know Dr. Zebradast has a project going on where they interviewed me, and I shared a lot of these ideas on this list. And so there's and this is going to take a long time to implement and execute, because certainly ophthalmology doesn't move that quickly, and with health privacy and all the other concerns that healthcare has, it's not easy to do all these things. And certainly also they require work on the AI and programming end as well. But I think it is going to be a very, very transformational event. So my goal today is really to think about not only how we can be forward thinking and how we use AI, and I think other people are going to really talk about that a lot more, but also what will become important after AI matures. And in many ways, those same things are important right now, but are going to become even more of the focus of our work. So I want to talk about two things. First, what are the limits of AI's knowledge? And then really, is knowledge enough to treat patients, or how do we use knowledge to treat patients more precisely? So let's talk about the first. So I think that this is a project that actually a couple of students reached out to me to do, and they provided me some very frequently asked questions in the field of glaucoma, the questions that people pose to Google and other AI models. And then they asked me and another doctor to grade them and evaluate them. So this is one of them, for example, that was very frequently asked, which is, what are signs of glaucoma? And this is what the AI model gave back. And it is something that probably is the canonical view, that people gradually lose their peripheral side vision over time. And they notice tunnel vision, where they gradually lose their ability to see objects off the side, but can only really see things in the center. And of course, then they, even though they're talking about particularly open angle glaucoma, they start talking about things such as halos around lights. And they talk about acute angle closure. So This is not really a very good answer, although it's not a surprising answer from what's out in the literature. There's certainly a lot of pictures which describe gradual loss of peripheral side vision. And I think there's a lot of concern over acute angle closure, even though it's a very, very rare event. And most people really don't have halos. So you see that still the answers that you're going to get from large language models are pretty incomplete and insufficient. In fact, some of them are probably pretty wrong, and I think this is one of the challenges of what we learn from online searches, is that oftentimes the truth is subtle, and really the conventional knowledge may not capture them. This, for example, is work that I had done with one of our current resident, Yesha Shah, which described the specific symptoms that people use engaging in describing their disease impact. And in fact, what actually shows up the most common is cloudy vision and missing patches of vision. And of course, people also do describe having worse peripheral vision, but I suspect that they probably have that because they think that that's what the disease is, because that's what they're told from online resources, as opposed to what that is actually experiencing. So I actually kind of always talk to patients about having cloudy vision or missing patches of vision, and gauging whether this is something which may be bringing them close to their disability threshold. This is actually a project we had done where we took patients who have only glaucoma damage in one eye and have a normal vision as far as we can tell in their other eye. And so we actually showed them a scene, and we had an artist applied to medicine student, actually modify the image in the good eye so that it looked like the bad eye, and then they would alternately show the two images to patients. And what you get is a whole bunch of different things, many of which are not really abnormal peripheral vision. For example, this patient sees like a little intermittent blurring right in the center of their vision, whereas this person sees like a mixture of blacking out and whitening out in areas that are actually pretty close to fixation. And this patient has like this big blackish, whitish blob, which really causes a big missing area, which abuts their central vision as well. So is knowledge going to get better with artificial intelligence? And I think it probably will, but the problem is that hallucinations probably will not. So this is a nice article written about a year and a half ago, which actually just talks about the ways that LLMs are structured and that hallucinations are really an inevitable feature of these systems. And there's really no way to eliminate them through improvements, data enhancements, or fact-checking mechanisms. So they really essentially prove that this is a mathematical certainty of this way of generating knowledge. So, you know, the power and creativity of this knowledge and their ability to say something which is really meaningful and very insightful at times is inherently tied to their ability to hallucinate, and you can't disentangle those. So as we look forwards, our need for knowledge and our ability to evaluate the validity of information is only going to increase. The other problem is that large language models cannot know what we ourselves don't know ourselves. So I think this is a work that really has spurred the work of Dr. Yohannan and R01, which hopefully is funded, which really talks about the fact that we don't really have evidence for a lot of the decisions that we make. This is an article that leads to that on primary care, which actually talks about the fact that even most of the decisions that your primary care doctors make are based on insufficient evidence. Either, you know, only about a fifth are really based on consistent, high quality patient-oriented evidence, and maybe half are based on expert opinion, and the rest are really based on almost no evidence whatsoever. So we kind of operate in a situation where we don't really have evidence for a lot of what we do, and this is especially true surgically, where we make tons of decisions, and it's hard to really have evidence for all of those. And of course, there's exciting new treatments and truths, which we ourselves cannot even imagine right now, and large language models are going to have very little to say about that. I think there's also many truths that are very subtle and not really in the book per se. So this is one question that I asked a large language model. What are the side effects of oral and carbonic anhydrase inhibitors? And it gave me what you would say is an accurate response, that they have problems to the kidney, CNS, erythrocytes, and it tells me what they're used for. And it kind of gives us some of the examples of the different things that it causes: paresthesia, fatigue, drowsiness, changes in taste, nausea, and also occasionally severe hematologic reactions. But what it doesn't really tell you is just the practical thing that a patient would want to hear, that this is a medicine that people really cannot usually tolerate for a long period of time. And so it does have serious side effects if used for a long time, but it really has use-limiting side effects, and I can go over what some of those things are for you. But I know that you really can't tolerate this for a long time. So it doesn't really tell you things in practical terms. Maybe the second and even bigger question is whether knowledge is really enough to treat patients. And so if we know, even if we know everything, are we really going to be at where we want to be in order to treat patients well? So for really good treatment, the question, first of all, is who needs to know and who needs to know what? Because I think it's essentially impossible for the doctor to know everything, even with the assistance of online aids. And of course, the patient will know even less in most cases. And nobody is going to know the future perfectly, even if they know the present well. And that's just inherently true. I think in the US, there's increasingly a growing model that really good care means that we know what's happening or what the future, our best guess of what the future is going to be. And we help patients get there as well. And then that the knowledgeable patient, in consultation with their doctor, is what makes the right decision. And that right decision is the best decision. So this is called the shared decision-making model. And so where doctors are supposed to seek their patients' participation, explore treatment options, teach them about the truth of those, and of course they could teach themselves these days as well, and then assess their preferences and values, and then help them reach a decision. And of course, we provide feedback to make sure that decision is a reasonable decision. So of course, that sounds very good. And I think this is essentially taken as a critical element of what we call patient-centered care. So something which is something that patients value, where they're really put at the center of the healthcare system. And in this model, it's really axiomatic or central that the patient involvement makes a decision good. And of course, there's ways of doing this with decision aids or conversation aids. And there is some evidence behind this that when you have shared decision making, there's less decisional conflict, better alignment of values, and less decision making where the patient is not involved. But there's really actually little or no evidence that it helps reduce costs, that it leads to less invasive therapy, or that it actually improves the patient's long-term outcomes. And of course, these are very important things that we're trying to achieve. And there's some serious limitations about shared decision-making. In other words, decision-making where we make people knowledgeable, and then that supposedly knowledgeable person makes a decision. And I think the reason is that patients really can't understand all the implications of their choices. Even if they are where they are right now, there's some things that are impossible to know, what the future brings, and what the details of that future are really like and what it means to them. And sometimes as the future evolves and changes, people's choices, even their retrospective choices, may change. So they may feel that they didn't make the right decision. And sometimes, even if you really try to understand what people value and what they want, they will make a bad decision. So there's a whole science on this, the rationality of patients and physicians. And I think there's extensive evidence that patients really are not rational. So first of all, they don't understand numbers or equivalence very well. And sometimes you can even manipulate what people decide by, if you have a diagram, what color the dots are on the diagram, where you show the bad events and the good events. Patients are often very biased towards recent or unrelated events. So if they had something bad happen to them with a procedure that has nothing to do with their eyes, they feel that they're going to have another bad event with their eye procedure. There's other fallacies that they bring in as well, either overconfidence or a feeling that they've invested so much that they have to keep on going. So there's a lot of irrationality that comes into decisions that's very, very hard to weed out and really get them to do the best thing for them. There are certainly things that we can do better, that we really need to be able to get better information so that we can help them make a good decision using very solid information. So this is one that was created by the National Health Service in England, trying to help people decide whether they should treat their glaucoma, and if so, whether with laser or medications. And so they show how often people will retain sight that's good enough to drive. Of course, even this depends on how bad their glaucoma is coming in. And then if you have eye drops or laser, how often are you going to need to use to start eye drops? And also, what are the problems with eye drops? How often are you going to get redness, blurring, discomfort? How often is your eye appearance going to change? And with laser, how often are you going to have problems such as redness, burning, discomfort, inflammation, and other things that affect your vision? So good things to kind of get people to try and understand, but even here it's very difficult. So this is one approach to actually decide what is a good decision by a patient. So it's actually something which has been used in certain studies as a reference standard for patients, where they actually, a couple's decision is based on each outcome, and then you can model the likelihood of outcomes based on the decisions they make, and then also have them give costs or burdens to each of those outcomes. And then ideally, a good outcome would be something which causes them to have an outcome which maximizes the things they value the most. So this is a detailed example that I've been working on with a couple of psychologists, where we're actually looking at a new patient with open-angle glaucoma and whether they should get medications or laser. But to really balance this, you actually have to look at the odds of various events, disease stabilization, side effects, need for multiple medications, surgery, and then you need to do that and provide a value for each of these things. And it starts getting very complicated very, very quickly. And in this model, a good decision would be something which actually gets people to make a choice which maximizes what they value the most and the probability of those things happening based on the decisions they make. I think you have to go back sometimes to an even more fundamental question of, well, why do we even know information in the first place? So this is kind of a summary of a lot of the work that I've done over the years, describing what the impact of glaucoma is on individuals. And of course, it increases their likelihood of not driving, being less active, being fearful of falling, and not leaving their home on a given day. And of course, the reason to know this is so we can treat patients, but also because of who we become and how we really approach our work in general. So I think we understand these consequences, and we want to know it as a science because we can apply that science, but we also want to know it in a way that really breeds empathy in our patient interactions and also leads to better patient decisions. So when we know when people can work and they read, do they have to stop driving? Do they have to stay at home? Do they fall? And do they become limited in their activities? We can really guide them in their decisions better. And this is also something which affects us. I think as we start understanding these things better, we become more empathetic. This is a work from a Stanford professor who actually shows that empathy is something which varies over time in populations and within the same individual and can be cultivated, and it's often best by seeing how other people are suffering. And I think we certainly learn from what we do in the same way. You know, we learn all of our field, surgical outcomes, risk factors, lifestyle, pathophysiology, genetics, IOP rehabilitation, based on what we observe in patients. And we learn our field not only to help people with better choices, but to really understand what these choices mean for them in their future lives. And we take this learning and bring it back. And this is the type of learning that an AI model really is going to struggle with, and which is why we need to really understand our field and really have practice of medicine so that we can help people make good choices. I thought this was a nice summary slide that I was going to end with because I thought it was a very moving article by a primary care physician at Hopkins who was reflecting back on his 40 years of clinical practice. And he really made the point that in his longitudinal care of patients, that he really tried to do his best, that, you know, he really was somebody who was a companion and an advocate, and he was there not only to make choices with them, but to reassure them and comfort them and to really help them know that they had a partner in their care. And I think when he did this, he noticed several things. First of all, he noticed that when he sent out an email telling everybody that he was going to retire, and he really noticed that a lot of people actually responded to it in a quite empathetic way back towards him. That they actually made a comment that they really appreciated what he did, oftentimes, even individuals who were very surly and not really fun to interact with really made a point that they appreciated him going the extra mile and listening to them and helping them make good decisions over the course of his career. And I think many of them actually were interested in his life and were empathetic towards him and what he would do next and really wished him well. And it was very meaningful for him. So I think that AI is going to certainly help us make better decisions, but I think we're still going to have to learn how we communicate better with patients to help them make better decisions. And I think that this partnership that we have to make with them is never going to go away.
Thank you, Pradeep. I mean, a very, very interesting topic, and you gave a very interesting message to people listening to this very important webinar. And I think the following talk, I think we're going to continue this in the next couple of talks, and then finally we'll come for a discussion panelist. So the next talk will be by Professor Karim Damji on holistic management of patients with glaucoma, and he talks about the BPSS approach, which Pradeep was just saying. With even in the AI world, I think this approach is so important. I would just briefly introduce Prof. Damji, whom I know for many years through the Sandwich Fellowship, which he used to do for people in sub-Saharan Africa, because he's so passionate of helping people across the globe. And that's why at present he is the professor and dean of medical college at the Aga Khan University in Karachi. And he's stranded at Abu Dhabi because of the conflicts which is happening in that part of the world. We hope that it resolves as soon as possible. So Karim has done his medical school at British Columbia, and then he did his glaucoma fellowship at Duke University. And then he's been working in University of Ottawa, and then he moved to University of Alberta, where I knew him during my visits to Canada. And he's been very passionate, especially for the developing world, the low and the middle income countries, where he started the sandwich kind of fellowship where African doctors can come to Canada, learn advanced techniques, and then they go back to Africa, where he goes and work with them in their hospitals. And I have met a couple of fellows who have done that fellowship, including Dan Kiagi in Kenya and a few other doctors in Ethiopia. So recently I was in Ghana and met a few of your fellows, Karim, even in Ghana, who had come down from Ethiopia. And that's the way he is reaching, especially the low middle income countries and the doctors who are managing glaucoma there. He has several publications and several other awards, including the recent humanitarian award from the American Glaucoma Society. Karim?
Thank you so much. Are you able to hear me okay, Venk? Or?
Yeah, perfect.
Okay. Thank you, Dr. Venkatesh, and I appreciate the invitation. My thanks also to President of the Tamil Nadu Ophthalmic Association, Dr. Sujata, and all the colleagues. It's a privilege for me to address you on this important topic of holistic management of the glaucoma patient. I don't have any relevant financial disclosure. And really what I hope is that by the end of this, you'll be able to apply biopsychosocio-spiritual paradigm when caring for patients with glaucoma. And I'll explain a bit more about what that is. Let me just see if I can get my, having a bit of difficulty with the slides here. So, all right. So when we set management goals, we often think about the quality of life of the patient and how to preserve and enhance vision. And of course, that's very important in addition to overall health and well-being. And we often focus on target pressures or other considerations based on the specific underlying etiology of the glaucoma. For example, patients with neovascular glaucoma might need a different approach to the underlying etiology, not only IOP treatment. Here's a patient who's in their late 60s that I used to follow in Edmonton. And they actually have this condition, primary open-angle glaucoma in both eyes. And as you can see, there's almost total cupping of the optic nerve and a very advanced field defect on the 24-2 up above and the 10-2 down below. And this, of course, would have an impact on their quality of life, as Dr. Pradeep demonstrated. And this would affect their well-being at home, during leisure activities, during work. They may not even be able to do the kind of work that they wish to do. They would have issues with reading and with tracking. Some of that is because of contrast or the effects, other effects on the retinal ganglion cells. Some, of course, is reduced peripheral vision. Some of it may just be lack of stereopsis that makes them more prone to falls. And then there's a risk of mental health issues as well, either anxiety or depression. And people may actually just isolate themselves rather than coming out and engaging in society. And this, of course, would create a burden for their care partners, their families, and possibly their communities. And in sub-Saharan Africa, as you were mentioning, Dr. Venkatesh, it's extremely common in some countries as well. So it can have a very profound effect on individuals in society. So the prevailing model until about the 1970s was the biomedical model, where we would try and understand disease based on systemic considerations, ocular considerations, and then try and manage that biology or adverse pathophysiology, if you will. But it was rather restricted. And in 1977, Dr. George Engel came up with this notion of the biopsychosocial model, BPS model, if you like, which takes into account the psychological and social cultural contexts of the patient. Now, one thing that I really enjoyed reading was an article by Dr. Chandrasekhar from LV Prasad, where he wrote and said, look, the tools of evidence-based practice are essential, but they alone cannot ensure the ability to deliver the highest quality patient care. The highest level of care also requires compassion and an understanding of the patient's personality, socioeconomic limitations, and cultural values, and not just the clinical and surgical skills or the tools of evidence-based practice. So this struck a chord with me, and over the years, I've been thinking about what additional contexts could be helpful as we seek to support our patients in decision-making. And this term, biopsychosociospiritual, is a little bit of a jargon term that I've coined, and it's BPSS, right? B is for the biological considerations, P for psychological, S for socioeconomic, and the other S for spiritual and cultural contexts. And keeping these things in mind, it allows you to unpack what is a rather low term, the holistic aspect, in order to optimize care for the patients. So let's think about this in a systematic way. How do we elicit these needs? First of all, when we see a patient, ideally we want to establish rapport by maintaining eye contact, by greeting them with their name, connecting with their family members or care partners. We want to have that empathetic ethos and take time to listen, not just with our ears, but with our eyes, with our heart, and try and understand where the patient's coming from. Often in the first 30 seconds, 1 minute, you'll be able to see what is happening and whether the patient is anxious, their family has some issues, and you'll be able to tell just by observing and having that encounter. Initially, of course, and this is particularly for the residents and fellows, just ask open-ended questions. How are you doing today? How is your general health? Any vision problems that you're experiencing or any concerns? And then, of course, patients will open up better than very specific focused questions, but then you can drill down into the focused questions, and we'll go through that in a moment. It's important to make a note of the chief complaint and then basically address that chief complaint. Patients may actually come in because of glaucoma, but their main complaint may actually be itchy eyes or some sort of allergy, and we need to make sure that aspect is addressed. So it's an important satisfied encounter. And then, of course, we need to collaborate and support patients in their decision making, as Pradeep mentioned, and that needs to be guided and customized individually, of course. Patients have, essentially given us their trust and confidence, and we need to make sure that we actually maintain that and build it over time. So in the history, we can go through these various aspects, but as I was mentioning, try and understand the chief complaint, but also the patient's overall demeanor, any concerns they have from the beginning, elicit their ocular history, systemic history, Now here, of course, in the systemic history, depending on the type of glaucoma or their symptoms, you may also want to find out a bit more about their past issues with intraocular pressure spikes, with hypotensive shock, trauma, things that they may have had in the past that give you optic nerve cupping that looks like glaucoma. And it may in fact be pseudoglaucomatous or an aspect of glaucoma that was elicited earlier, but now is stable rather than progressive. And then, of course, you want to make sure that you get an idea of their cardiometabolic status, any history of migraine, particularly if you're thinking about low tension glaucoma. And then their medical history becomes important, including their medications. Some medications, of course, will play into the glaucoma diagnosis, such as steroids or medications that dilate the pupil and maybe trigger an angle closure attack. Patients' previous surgical history, their social and occupational history, that becomes very important, of course, in terms of what they wish to do in their lives and how they wish to use their vision. And then the family history. And here it's important to ask if they know whether anybody has glaucoma, but also what age of onset or if they've lost vision. It's important that we understand how it plays out generation to generation, and that'll also guide the treatment as well. Not only for the patient, but it's important to think about the support that patients have in order to optimize their care and well-being. And when we're doing the exam, we want to do a meticulous exam from the front all the way to the back and document our findings. Things like exfoliation syndrome, which of course we can see on the lens or the pupil margin, or perhaps in the early stages just through heavy pigmentation in the meshwork, are important to document either as present or no evidence to support this at this point in time. And then you want to be able to double check the intraocular pressure, think about corneal hysteresis, corneal thickness, as an important variable as well. Consider writing the time down that the pressure was taken because there's fluctuation throughout the day or visit to visit. And then be able to document the status of the anterior chamber in terms of the angle, look at the lens and the iris carefully, the retina, all the optic nerve findings that may be there. If you're able to draw it, of course, that'll be ideal, or take a photograph of the optic nerve. But even if you can't, a good description is important. And then what are the appropriate diagnostic tests? Now, some patients may not be able to do functional testing with visual fields very easily. So confrontation fields in that setting may be helpful, or if nothing else, an Amsler grid or some other way of documenting the baseline visual field. And then, of course, structural testing can be done with OCT, and you can also do other ways of documenting their function, their structure. So with all of this, you can come up with the diagnosis or differential diagnosis, and then look at setting an appropriate target pressure, but also the underlying factors that may be at play. And we'll hear more about angle closure, but in some cases, removal of the lens may be quite effective. In neovascular glaucoma, you need to look for the underlying cause, as I mentioned earlier, and manage that. And it may involve systemic controls of diabetes. So all of that becomes very important. However, when you're explaining to patients, my suggestion is keep the language very simple and straightforward. And here, this may take a little time. So if you involve your care team, because we're often working as part of an interprofessional team with technicians, nurses, optometrists, technologists, etc., and many learners. And so we can also engage them so that the patients have a little bit more time with explanations, as long as we're all aligned on what needs to be done and explained. And then we can focus in on where our skill set is most optimal. So aggressive pressure lowering, of course, based on evidence is important, but also taking time if surgery is needed to explain the risks, the benefits, and in a way that is intelligible for the patients and their care partners. Offer some realistic hope. And I think the worst thing we can do is to say to patients, look, there's nothing I can do for you, even if they come with late presentations, because there are things we can do in terms of support. And I'll explain that a bit more as well. And then if patients have a lot of questions or are feeling uncomfortable, you can always offer an opinion from a colleague, or they can seek out an opinion, which is often helpful to reassure them on what is important decision-making for their future. So this is the paradigm that I'm sharing with you, and I'll just go through it a little bit further. Here, in terms of the biology, we're thinking very carefully about the type of glaucoma, the mechanisms, but also the systemic health, the life expectancy of the patient, and looking at their ability to have sound orientation and mobility and to remain safe in their environment. Some patients present extremely late, and they may have loss of vision with high intraocular pressure, what we call absolute glaucoma. And the goal there may not be realistic in terms of restoring or protecting vision, but it may actually be more realistic to control pain or to have a better cosmetic effect. So again, listening to the patient and seeing what their need is becomes very important. And then we can support them accordingly. I mean, if pain is not well tolerated or managed even with medication or with diode laser cyclophotocoagulation, etc., then it may be appropriate to offer them retrobulbar, chlorpromazine, or alcohol, or to consider options such as evisceration, enucleation with a prosthesis in extreme cases to give them some relief or a better cosmetic result. And then, of course, patients often have underlying anxiety or mood changes and sometimes full-blown depression because of their ocular condition. And so some patients will present with hallucinations and sometimes visual hallucinations, auditory hallucinations. And we have to make sure, of course, that they have no underlying psychiatric or neurological problem, but it is fairly common, Charles Bonnet syndrome, and we can reassure patients that this is just part of their condition when they start losing vision, that the brain actually starts to create these additional hallucinations. So that can be quite concerning for some patients. And if we're sure that there's no underlying pathology other than the vision loss from glaucoma, then we need to reassure patients. I think one needs to put yourself in the patient's shoes to really feel and experience what they're going through. And again, taking time to listen and just observe is very important. And then if their family members are concerned, or either way, because the glaucoma can be hereditary in many cases, it's good to ask the family members to also have an eye exam. In terms of the, so now I've talked about the biological and psychological considerations. The first S in BPSS is the socioeconomic factors. And here we need to think about the context and the social environment that the patient has, their employment, and then make sure we advocate and support them. For example, parents that have children affected with glaucoma may be likely to pull them out of school. In Pakistan, that's quite common. And so I spent some time trying to help patients and parents understand that actually it's fine as long as they can be supported with various aids in the school system or through home tuition, and to be able to continue that journey to optimize and live life to the fullest rather than just, stopping their journey and having them isolate themselves at home, which is an instinct, of course, that is quite common. And then what can we do to assist patients if they can't afford drops? Maybe SLT or some other laser therapy is the best choice, etc. And finally, in terms of spiritual and cultural values and beliefs, as Pradeep was alluding to, that becomes very important as well. So here the word spiritual is not necessarily a faith-based perspective, but ask yourself, or try and understand what is it that gives people meaning in life, and what are their underlying ethics and values, and what do they want to know more about? And they may wish to explore with you lifestyle, mindfulness, meditation, exercise, whatever it might be. And of course, there is evidence in some cases to support some of these practices, including mindfulness, meditation, prayer, etc. And they're alternative or complementary therapies. And as long as these don't interfere with what we're prescribing or suggesting, I'm personally am okay with patients who are seeking out herbal medications or acupuncture, other therapies, because I think they need to feel comfortable that they're doing everything possible to deal with what is actually a really difficult condition or a group of conditions. So to summarize, I hope that I've been able to help you understand better, and hopefully you'll be able to apply this biopsychosocio-spiritual concept. And in addition to the medical treatment and surgical laser options, I think it's important that we also consider essentially what is a vision rehabilitation holistic approach, which means magnification, lighting, optimizing their vision, but also their orientation and mobility so they can feel safe in whatever circumstances they're in their daily living. psychological support as appropriate, and sometimes that may mean referral to a psychologist or a psychiatrist, or simply just reassurance that's appropriate. Engaging their care partners and their family members, and in some cases, support groups may also be available, or you can actually help initiate support groups. And then finally, thinking about their spiritual and cultural context and what else is important, and addressing those aspects as well. And with the care team, that interprofessional care team, so that you don't have to take a full burden of what's happening, but be able to and are good at. So I hope that's helpful. Thank you so much.
Thank you. Thank you, Prof. Damji. I don't think anybody else can make this topic so interesting, BPSS approach, which we heard several years back. But with all the new evidences, with all the AI, I mean, this approach is so important even today. There is no doubt in that. And let's have some discussion at the end. I hope your signal is fine. And it continues to be a little spotty as we expected, but once in a while, your voice was breaking. Otherwise, everything was perfect so far. Thank you again. And next, we'll have one of my another good friends, Dr. Jitin Yohannan, who is the Bonnie Pickens Rising Professor of Ophthalmology at the Wilmer Eye Institute. He did his residency in Wilmer when he has visited a few times to India and also to Pondicherry. And since then, he has done fellowship with Professor Aik Ahmed at Canada in MIGS, who is an expert in MIGS. Not only in MIGS, now he is an expert in artificial intelligence. He's been working with a lot of young residents and engineers in AI algorithms to aid in diagnosis and management. So he is going to share with us the signal in the noise, an evidence-based framework for precision glaucoma monitoring. Jitin?
Thank you, Venkatesh. Hopefully you guys can hear me okay.
Yes.
So great. So it's nice to see some familiar faces and old friends, and I really thank the committee members for inviting me to talk and share some guidance on essentially some best practices to monitor for glaucoma progression. Let's see if I can advance the slide here. So these are my disclosures. I do consult for Topcon, who makes visual field and OCT devices. So this graph shows one of the main challenges we face in glaucoma care. So on the x-axis, you see time, and on the y-axis, you see mean deviation of the visual field. And the blue line here represents what is happening to an individual patient's measured mean deviation over time. And you can see between any three tests, the visual field mean deviation may be stable, it may be decreasing, it may be increasing. So there's a lot of test-to-test variability. But if you look at the long trend of visual field change over time, the true signal is indicated by this red line. You can see if you follow this patient with many tests over many years, there is a moderate rate of decline of about 0.5 decibel per year. So our challenge in glaucoma is trying to isolate this red clean line, which is the true biological signal, from this noisy blue patient response that we see in our day-to-day clinics. And so how do we do this? So I'm going to try to leave you with 3 takeaways to improve our chances of detecting that red line of true disease change. And the first point is that we in general need to do more testing. So this is some work done by Chris Bradley in our group, which essentially assessed how many tests you would need over the course of 2 years to accurately detect rapid progression, which is defined as a rate of visual field change of worse than 1 decibel per year. On these figures, you can see on the x-axis is the number of measurements that were done over 2 years. And on the y-axis is the accuracy of detecting that rapid visual field change if that number of measurements were done. And you can see in order to detect disease worsening with 50% accuracy, you would need about 12 OCTs over the course of 2 years. And if you get 12 visual fields over the course of 2 years, you're running around 30 to 40% accuracy at detecting that rapid change. And that's because the variability of these patients that are progressing very quickly is actually quite high. So it's really hard to detect that rapid change. If you want to detect progression with 70% accuracy, we found that if you combine both visual field and OCT testing, you're able to do that with about 12 data points over 2 years between the two tests. So about 6 visual fields and 6 OCTs over 2 years. But we know that having 12 patient visits over 2 years is highly impractical. It's impractical in the US, and it's probably impractical in India as well. And so are there strategies that we can use to try to get that data in fewer visits? So rather than having the patient come back 12 times in 2 years, one of the strategies that you can use is clustering of tests. And by clustering of tests, I mean that you can do multiple visual fields or multiple OCT scans on the same day. And in the figures before, clustering actually leads to a statistically significant improvement in the accuracy of a given number of tests. And the reason for that is because when you cluster tests, the variance of the visual field actually declines and the time between tests increases. And I'll show you on a later slide how that works mathematically. The nice thing about clustering is that we can actually leverage newer testing strategies. So if you have access to the HFA3 machine by Zeiss, you have access to the CETA faster protocol. And that protocol cuts the per eye test time to a couple of minutes for a visual field. And so it is possible to do multiple tests on a day when you're able to test more quickly. And Jack Fu from Australia has done some really nice work on showing the advantages of these clustered testing approaches with CETA faster. So this slide shows why clustering actually works mathematically. And the reason is because it reduces this variance equation. So the numerator is essentially a noise measurement, and the denominator here is the time between tests. And when you cluster tests, you reduce the numerator here. So you're reducing the variance by reducing both the numerator and increasing the denominator. So on the numerator side, because you're doing multiple tests on a day, you're averaging the noise, and this value decreases. And because you're only doing fewer measurements over time, so let's say at the beginning and end of your 2-year period, this value actually increases. So the total variance actually decreases, which decreases your noise in relation to the biological signal. The other way to actually get more data is to only selectively test patients that you think are higher risk. So this is kind of using a Bayesian approach to testing, where if you think, the likelihood that a patient will get worse is related to, how likely it is that similar patients with those characteristics will get worse, that patient's rate of worsening on the visual field or OCT, as well as the reliability of the visual field and OCT that you're getting. So if you have a patient that has a high risk of worsening, because similar eyes tend to get worse pretty quickly, has a high rate of worsening on their current visual field in OCT, and has a highly reliable visual field in OCT on that visit, then they're very likely to get worse. Whereas if the opposite's true, they're unlikely to get worse. And really what we should be selecting for is these patients that have a high base rate of worsening. And we can use clinical judgment to do that. So we should frequently test those patients that have more severe or advanced glaucoma, that tend to have higher IOPs, patients that only have one eye, or have disease types that are likely to get worse pretty quickly. And one of the classic examples of that is pseudoexfoliation glaucoma. The other way that we can select for the eyes that we want to test more frequently is to use AI models. And this is a paper published by Patrick Herbert in our group, where he essentially used baseline OCT and visual field tests and combined that information with clinical information such as demographics, their pressure readings, their disease type, to essentially output the probability of rapid worsening in the future. And these models actually achieved reasonable performance. So if you gave the model a set of visual field OCT and clinical information from baseline, it was able to achieve an AUC of about 0.77. If you gave the model 2 baseline visual fields and asked it to predict rapid progression over 5 visual fields, the AUC improved to above 0.8, which is within the realm of clinical usability. Okay, so takeaway 1 was all about frequently testing those patients that are at higher risk. We can enrich for those patients and we can cluster the tests to make those, that takeaway more practical. Takeaway 2 is about not throwing away good data. And so, our group has done a lot of work looking at the effect of reliability metrics on visual field performance. And so if you look at the Humphrey printout, once fixation losses go above 20 to 30%, the Humphrey machine marks the field as unreliable in many cases. And so we actually asked the question, how impactful are these metrics, such as fixation losses, on mean deviation? And Dr. Romelu actually collaborated on this work. And what we can see on this graph is the reliability index, the percent of the reliability index on the x-axis, and the error in mean deviation on the y-axis. And so the green line represents the impact of fixation losses. So as fixation losses increase, they have very little impact on mean deviation. So if you look at other metrics, such as false negatives or false positives, they tend to have a larger impact on mean deviation. So false positives, which are indicated by this red line, tend to have the largest impact on mean deviation, and they tend to skew mean deviation more positive. So they tend to make the visual field look better than it is. So even as little as 15% false positives can have a significant impact. False negatives, on the other hand, tend to have a moderate impact on mean deviation. And they tend to actually make the visual field look worse than it is. So the higher your false negatives, the lower your MD value tends to be from the true value. But you have to keep in mind that false negatives are less likely to have an impact in severe disease. And many patients with advanced glaucoma tend to have high false negative values just from the disease process itself. So on this slide, I just want you to remember that don't throw away visual fields because the fixation losses are high, because they tend to have a little impact on mean deviation. So if you're looking at the point-wise data, yes, fixation losses will have an impact, but if you're looking at mean deviation, they tend to have very little impact. And the same can be said of OCT. So again, we asked the question, how much signal strength noise, or how much degradation in signal strength actually causes a significant change in your OCT RNFL thickness measurements. And that's what this graph shows, which shows signal strength on the x-axis and the RNFL thickness measurement error on the y-axis. And the blue data shows OCT scans that don't have any artifact. Artifacts are these black areas that you often see on the Cirrus machine that are errors in segmentation. So the blue line shows OCTs that do not have this artifact. And you can see in general, a signal strength of the OCT decreases from about 10 to 3. It tends to have very little impact on RNFL thickness measurements. Once you get below a signal strength of 3, it tends to have a major impact on on RNFL thickness measurements. In the presence of artifact, though, which are, again, these black areas, you can see that RNFL thickness measurements are significantly affected no matter what the signal strength is. So they drop quite dramatically. And you still see this relationship with where the signal strength tends to get worse, less than -3. So for OCT, don't throw away tests just because they have a signal strength less than 6. That's what the Cirrus machine often does, is it disregards those tests. Really, you want to look for the presence of artifact on OCT because that's the major driver of this RNFL noise. And the one other pearl here is that artifacts tend to be local. So if you have an artifact up top, it's only going to affect the segmentation of the OCT here, and it won't really affect the inferior quadrant. So you can still follow the inferior quadrant thickness over time, even if the superior quadrant has an artifact in it. And the final takeaway is understanding when to use which test to monitor glaucoma progression. And so today we're lucky to have generally 3 different metrics to track progression, 2 structural and 1 functional. And so we have retinal nerve fiber layer thickness, which is represented by this blue line, GCIPL thickness, which is represented by this purple line, and visual field, which is represented by this black line. And this graph essentially shows disease severity on the x-axis, so how far advanced is the glaucoma, and then the signal to noise ratio of that measurement on the y-axis, which is essentially the rate of change over the variability. And so Alex Pham, who is an excellent medical student and now a resident at Maryland, who worked with us, looked at these signal to noise values across the range of disease severities in our data set. And what he found was that for very early disease, so eyes with little to no visual field damage, RNFL tended to have the highest signal to noise. Once you get to MD values of less than -3 to above -12, GCIPL tended to have the highest signal to noise. And then once you get to more advanced disease, visual field tends to have the highest signal to noise because these structural measurements tend to reach a measurement floor. So again, in early disease to suspect disease, RNFL is probably the best in most patients. In moderate disease, GCIPL probably is better than RNFL or visual field. And in late disease, visual field is going to be the best because the OCT reaches the floor. So in summary here, in order to increase that signal to noise ratio, you need to increase data volume. You need more data than you think. Consider that clustered testing and using the faster protocol to cluster testing. And then you really want to focus this higher testing density on the patients that are at highest risk for deterioration using either clinical judgment, which we have now, or AI tools, which hopefully we'll have access to in the future. You want to filter wisely, so don't disregard good data. So ignore fixation losses if you're using mean deviation to follow visual fields, and don't disregard OCTs that have a signal strength less than 6 unless there's an artifact on those OCT scans. And then finally, know the floor for your various measurements. So in general, RNFL tends to be best in suspect and mild disease, GCIPL for mild to moderate disease, and visual fields for more advanced disease. And I'd like to thank our group for all the hard work they've put into the data that I presented. And thanks again for inviting me to speak.
Thank you, Jitin, for highlighting the signal in the noise. I keep hearing this voice very often, no, for some of the movies which we made together. An amazing voice. I can hear the noise in the voice, but thank you again. So the last talk for today, before we have a discussion, will be by Nasli Zabardast. She's an assistant professor of ophthalmology at the Harvard Medical School. She did her medical school from Yale University, and then she went on to do several programs at Johns Hopkins, including a residency and glaucoma fellowship. And then after a few months after the fellowship, she moved to the Harvard Medical School, the Mass Eye and Ear, where she is the director of glaucoma imaging, focusing on adult glaucomas, and also she does a lot of minimally invasive glaucoma surgeries. And she has played a very active role in the study which we conducted many years back at Pondicherry, when she had made several trips, not only to Pondi, but across the system. So she knows each and every hospital of Aravind and how it functions, to do the Indian family angle closure evaluation. And I want Nazli to share angle closure glaucoma revisited and her insights from the iFace study.
Thank you so much, Dr. Venkatesh, for the kind introduction and for the invitation. Let me share my slides here. All right, does that look okay?
Perfect.
All right, great. So now for something completely different, I want to talk about angle closure glaucoma. This is work that I had the privilege of helping out with when I was a medical student and a resident at Wilmer, together with Dr. Pradeep Ramalu, Dr. Venkatesh, Dr. Kavita, and many others. So we know that primary angle closure glaucoma is a leading cause of irreversible blindness worldwide. And yet, despite the shared anatomic risk factors, some eyes seem to remain stable for decades, while others seem to go rapidly blind. And today I want to explore this paradox a little bit and what we have learned from the iFace study, what it tells us about the complexity of this disease. These are my financial disclosures that are not relevant to this talk. So first, it's important to review the definitions of the stages of angle closure disease. So the stages are commonly defined based on the ISGEO classification guidelines. PACS, primary angle closure suspect, is defined as a presence of iridotrabecular contact of more than 180 degrees, but with no signs of secondary effect. Whereas primary angle closure is the presence of iridotrabecular contact, but with evidence of either pressure elevation or peripheral anterior synechia, as shown here. And then primary angle closure glaucoma requires to have glaucomatous changes defined by the optic nerve changes and visual field changes. And then there's this other entity of acute angle closure crisis that presents with pupillary block and very high intraocular pressure. We do know that primary angle closure glaucoma is a major cause of blindness worldwide, and even though it's less than half as prevalent as primary open angle glaucoma, it accounts for more blindness related from glaucoma worldwide. So currently about 5.3 million people estimated to be bilaterally blind from this disease, and it's a huge problem in Asian countries, including in India. And if PACG is a problem, PACS is an even bigger problem that accounts for about 10% of the adult population in Asian countries. So it's about 3 to 5 times more prevalent than PAC and PACG. So the question really becomes, how do we find all these people with angle closure glaucoma? Historically, we've considered PACS as defined by gonioscopy to be the risk factor for PAC and PACG, but it's not practical to screen 10% of the population, especially considering that only about 10% of those with anatomic angle closure have true glaucoma, and this was evidence from the Chennai eye study. So, but the question comes up, is PACS really the risk factor for PAC and PACG? And to answer this, we turn to the Zhongshan Angle Closure Prevention Study, the ZAP trial, which randomized eyes to laser iridotomy versus observation. and followed 889 PACS patients for up to 6 years. So from this study, we can see that at 72 months, those that were randomized to receive laser iridotomy had a reduced incidence of IOP elevation, PAS formation, and acute angle closure attack, but that this rate was very, very low. So only about 4.4 out of 10,000 eye years rate of events in untreated eyes, which seems to suggest that most eyes without treatment were just fine and nothing really happened to them. So we have this paradox. We have a high rate of angle closure related blindness, but we have infrequent progression from what we consider to be its main risk factor, PACS. So that raises the question of PACS as currently defined may not actually be the true risk factor for PACG. So how do we identify those eyes that are at risk of vision loss and are at risk of blindness, as we can see in our population studies? That takes me to iFace-1. iFace-1 was a pivotal study done together with Wilmer Eye Institute and Arabian Eye Hospitals, and it was designed to understand if family history is a major risk factor for angle closure. It compared the prevalence of angle closure in sibling pairs that had open angles that had PACS and those that had PAC-PACG to determine the heritability of this disease. iFace-2 was a follow-up study to iFace-1, which served to determine if severe stages of angle closure, defined by PAC-PACG, were more common among siblings of patients that also had more severe stages of angle closure compared to siblings of those that just had the risk factor phenotype, specifically PACS. So it was to determine this particular odds ratio. And in this pivotal study published back in 2014, iFace established family history as a strong risk factor for angle closure glaucoma. So siblings of angle closure subjects had more than 1 in 3 risk of prevalent angle closure and about 14 times greater odds of having angle closure compared to open angle siblings. This was quite impressive. In iFace-2, we also found that the odds of advanced disease, specifically PAC-PACG, such as elevated pressure, PAS, and glaucoma, were higher in siblings of individuals that had also severe disease compared to those that just had PACS. So what do we learn from this study? We learned that both PACS and PAC-PACG siblings had higher prevalence of angle closure compared to controls and general population, so that angle closure is a highly heritable disease, but it's particularly heritable when in its more severe stages. So while PACS siblings had a prevalence of angle closure glaucoma that was comparable to that of the general South Indian population, those that had siblings with severe disease had nearly 3 times the rate of having severe disease also compared to the general population. So these findings suggest that there may be 2 sets of genetic risk factors. One for uncomplicated iridotrabecular contact, so whether the anatomy is present, and another set of genetic risk factors that determines a tolerance to that iridotrabecular contact, so whether that progresses to glaucoma and pressure elevation. Alternatively, it might be that siblings of individuals that have more severe disease have earlier onset of iridotrabecular contact and therefore earlier disease progression. So what is interesting is then we looked at anterior chamber parameters within the iFace population among these siblings And this was work done by one of the current residents at the Wilmer Eye Institute, Liz, pictured here, where we looked at anterior chamber parameters and found them to be highly heritable among sibling pairs. But what was interesting was that lens thickness and lens vault were more heritable among concordant siblings than discordant siblings. So this suggests that there might be heritability of these particular biometric features that contribute to angle closure pathogenesis. So not surprisingly, genome-wide association studies have shown that there is a genetic basis for angle closure glaucoma. And though this field is not as advanced as genetics of primary open-angle glaucoma, to date, multiple large genome-wide association studies have been done and have identified 8 genetic risk variants associated with PACG. Some of these genes influence anatomic features such as lens vault, shallow anterior chamber, pupil dynamics, and others are involved in trabecular meshwork functioning and intraocular pressure. So this is what we call the age of precision medicine. So together with artificial intelligence, the rise of genomics is allowing us to understand people's liability to disease better. So what we can define, you may have heard of genetic and polygenic risk scores. So a genetic risk score is when we combine common variants that individually don't increase someone's disease risk by much, but together can tip the balance towards disease, as you can see here. So for example, if we have 7 disease-causing variants, and a patient may have 4 of them, their genetic risk score would be 4 out of 7, to put it simply. In fact, work has been done in creating genetic risk scores for primary angle closure glaucoma. This was a paper out of Singapore, published in 2021, that showed that those that were in the highest quartile of genetic risk for PACG had higher risk of having severe disease compared to those that were in the bottom quartile of genetic risk. Now, with the advent of large-scale genomics and clinical data, we can go a little further in building these genetic risk scores, and we can build something called a polygenic risk score. So instead of just looking at those 7 variants, for example, that I showed you that were associated with disease, we can look at the entire genome, and we can look at some of the variants that increase risk, some of them decrease risk, and most of them are somewhere in the middle. So when we plot this on a population level, we have individual 1, for example, that has low risk of a particular disease. Individual 3 might have a high risk of that disease because they have a lot of genetic hits for that disease, and most people fall somewhere in the middle. So does this work in practice? Well, we use data from the UK Biobank, and this is one of our current residents at Mass Eye, Sayuri Sekimitsu, who led this study. And we found that polygenic risk score for angle closure glaucoma, even though, remember, the field is not particularly advanced, so we don't know much of the genetics of angle closure glaucoma, it still was pretty good at picking out subjects that had angle closure in a largely healthy biobank. Additionally, we wanted to see if this genetics interacted with risk of environmental or other risk factors. So we know, for example, psychotropic medications are a risk factor for angle closure glaucoma. And we looked at this interaction and found that if you had a higher genetic risk for the disease and you were exposed to psychotropic medications, your risk of disease increased exponentially. So ultimately, we have effective treatments for this disease. This is a very anatomic disease, and we know how to fix it. The problem is, how do we find individuals that are at risk of blindness? Ultimately, we need to find better ways of identifying people that are at high risk, so these higher risk phenotypes through longitudinal and better imaging studies. And then importantly, I would propose that we really need to understand the genetics of this disease better. Like I said, we only know about 5% of the genetic susceptibility to angle closure glaucoma. And to really understand personalized risk for our patients, we need to know their genetic liability better. I'd like to thank my funders and everyone in my lab who contributed to this, as well as all our wonderful collaborators. Thank you.
Thank you, Nasli. I mean, it's always a pleasure to listening your talk on iFace. Even though we looked at all these papers and data very carefully, I mean, it's so interesting the way you put forward some of your thoughts. Thank you again, and I'll open it up for the panel. If you have any specific questions to the speakers, or you want to add any points, starting from Vijaya Madam.
First, I want to congratulate for the excellent talks, and really enjoyed excellent talks by great speakers. So I just wanted to make a small, I have a question for Jatin. I like the concept of the cluster. It is something new to us. We don't practice it. When you say cluster, you showed one graph where the clustering was done at the beginning and 2 years later. Is it on the same day or few months you do the clustering?
Yeah, so let me see if I can, yeah, so you can do it within a short time period, and I guess there's debate over what that means, right? So in the typical setting, it means like the same day. So you do multiple visual fields on the same day to reduce back and forth trip to the clinic. So I think that my hunch is if you do it on the same day, the variance will be lower, and you'll probably get a more consistent measurement. But the question is that the true biological signal if you do it the same day? Because you may want to spread it out over a couple of days to actually capture a little bit of that noise and actually get to a better average value. So that actually remains an open question. And we are looking, at least in the setting of OCT, we have some optometrists that we're working with who are doing this study where they are doing repeat OCT measurements within a few minutes of each other versus within a few hours of each other versus within a few days of each other. So hopefully we'll have the answer to that question soon. But my hunch is if you spread it out over a little bit of time, not too far, the actual value will be closer to the truth.
I assume the variability is likely to be more with the perimetry rather than with the OCT. Why do you think you still need so many tests on a single day?
For OCT? Yeah, so actually though, people think that OCT is less variable, but it's actually quite variable, especially the Cirrus machine, because I think the segmentation on that machine is not super refined. And so you can get variable RNFL thickness measurements from test to test. I think the average variability is about 5 microns. So if you see like a 5 micron change in a quadrant, that could be noise, or it could be true disease progression.
Okay, if I'm allowed to ask one more question, it's more of a comment to Pradeep. I think he beautifully brought out what are some of the limitations we have with the AI. I think the hallucination part, what you mentioned, is a very, very important, especially when you're using the large data. I think the hallucination also can vary depending upon who is using the AI, depending upon what you are looking for. It can vary from person to person also. And I really like the last slide, the 40 years of experience. AI is going to be part of our management of the patients, whichever is the subspecialty, but it cannot take away the experience of a surgeon. The 40 years experience of a surgeon in patient care cannot be taken away by the AI. At least that is my understanding. Do you agree, or you have anything else to comment about it?
Yeah, I mean, I agree. And I think that a big part of it is that there's just a very emotional component of taking care of people. And so it's not really all factual. I mean, we use all these facts to really guide things, but I think as Dr. Damji really nicely demonstrated, that there really is a psychosocial and spiritual component of our interactions. And it really is a very emotional connection, and there's a very emotional component of disease as well. And it's probably not impossible that AI, if it were in the room and listening to all these things, couldn't actually quantify and parameterize all these emotions. And it would probably say the right things also. But that's not what people are looking for. People are looking for an actual human being to respond to those emotions in an appropriate way and to validate them and to help them through them. And I don't think AI is ever going to do that, because it's not a person. Even though it probably could understand them and say some of the right things, it's just it's not actually feeling them, and it's the actual feeling of it which really matters.
Anyway, I think thank you very much for lovely talks. All four of you have really gave us a lot of insight. Maybe others can.
Yeah. Krishnadas sir, you have any thoughts or you have any specific questions to the business
Yes,
approach?
thank you. First, thank you all of you for a wonderful evening of learning. I had two questions from where Nazli left off. But before that, my question to Dr. LV and Pradeep is, why do we have to presume that AI will not exhibit emotions? Recently, I had a short video sent in one of my college groups, which brought back to life the Tom and Jerry, which we all used to see in the young. And this time, both Tom and Jerry have become very old. And one of them, I don't remember who is who, but he wants to see the other one. And he goes, he hears that Jerry, let us say Jerry was unwell, and he goes to the hospital to see, and finds it very disturbing that Jerry was not there on the bed. He presumes a lot of things. But then a nurse brings him, and when they see, no, there's so much of emotions exhibited on the animation, which is unimaginable. So just as a funny takeaway, I was just thinking, anything is feasible, of course. I agree that it cannot replace the human component. And if you recall the first slide of Pradeep, which said potential applications of AI in medicine, it's all supplementary, complementary, things like managing the schedule, managing counseling, answering questions. And nowhere there was any decision making or heart-to-heart conversation with the physician and the patient. That shows that still it either at least a human oversight is required, or human interaction. And as Madam said, experience cannot be replaced at all. We all agree. If I have a couple of minutes, I just want to ask Nazli, I just want to take off where she left off on the last slide. Are we anywhere near predicting based on genetic screening which PACS individual will progress to angle closure? And a related question is to both Nazli and Pradeep will be, are we anywhere near an AI model which based on certain data inputs will also help us to predict which PACS patient will progress to angle closure?
So I think the area of genetic risk is much more advanced for primary open angle glaucoma, because we have many, many more risk variants, over 300 at this point. And there's a lot of evidence that high genetic risk predisposes to more severe disease and even progression from ocular hypertension to POAG. For angle closure disease, I think one, because the studies are limited, we don't have those genetic risk factors yet. So I think the first step is to really do larger genome-wide association studies. And then we really need these longitudinal data sets that we're really lacking, right? We don't really have good data sets that have individuals that have been followed over time that have progressed from PACS to PAC, PACG versus not, that also have genetic data available for analysis. And that's sort of where the link is missing. So I'm hopeful that, in the near future, with the advent of more biorepositories, that we're going to get there.
Thank you, Nazli. And if I have a sibling with PACS in a a sibling of a patient with the PACG has PACS, do I treat or observe? The risk is higher. So do I treat this patient sibling with suspect?
So if I had a patient that had PACS who had siblings with PACG that had progressed to blindness, vision loss, glaucoma, yes, I would do an LPI in that eye.
We will do that. Yes, thank you.
Yeah.
Thank you.
Pradeep, you want to add anything on that?
Oh, I think that Dr. Krishnadatha's question is spot on. And I think the work that Nasli and the other geneticists are doing will eventually probably give us very good guidance as to what somebody's risk factor is with regards to progression from PACS, and maybe even stages that are before PACS. But I don't think we're there yet. So I think right now we're still left in this limbo where we're using things such as, do you have a family history of somebody with actual elevated pressures of glaucoma, or do you have other risk factors that are worrisome, or do you just have a high level of concern about a sudden attack? So I think we're still in that situation. I do think that will change, but it may be a while before it changes.
Okay. So Satyan and Kavita, do you have any?
Yeah. First of all, Venki, sincere thanks to you for wonderful arrangements. And
Oh,
You muted, Satyan.
it's Sachin.
Your audio got muted.
yeah, sorry. Thank you, Venkatesh and TNOA for arranging this wonderful meeting today on World Glaucoma Awareness Campaigning. Unfortunately, the GSA is not doing this World Glaucoma Week as the AIOS is next week. So we'll be just postponing it to the last week or so. So having said that, just to understand from, I sincerely thank all of you for your wonderful presentations. I have few of my comments. One is on Pradeep's talk on the LLMs, and I'm sure Pradeep is doing more on the deep learning as well as on the machine learning part of it as well. So to Dr. Pradeep, I'm just really interested to understand on one thing. Without the fundus photography, looking at only the OCT and the visual fields, going in and understanding about the disease as such and trying to develop models, is it really very meaningful? I'm not sure about that, because whatever I have seen, if we are not able to correlate with the fundus photography, and especially looking at the pie chart of OCT, for me it is completely kind of looking a little less meaningful than looking at the graph, fundus photography, and also the looking at the visual fields together makes a lot of difference in the way that things are happening. And regarding Dr. Karim's wonderful talk, I just wanted to comment only one thing. As a physician, clinician, physician, or a surgeon, whatever we are, say, for example, if the patient is only 30 years or 40 years of age group, and if he has a disease, as a clinician, we just advise, looking at the IOP, we just advise, okay, you take your medications regularly throughout your rest of your life. How hard it is for the patient to go through that. It is making the patient in our decision making in the treatment, makes a lot of difference with emotional content. Otherwise, it is going to be a tough job. As we all know that the follow-up rate, especially in glaucoma at the end of first year, in the compliance is only about 20%. So we are not even looking at the SLT or surgery or an MAGS, the new entrant, is we are not even looking at an option, because the compliance is going to be such a great issue. And if you're not going to treat our patients, they're ultimately going to go for a complete kind of a blindness. So in the PACS, I just wanted to understand, or I just have my own comment. Looking at the optic nerve head alone as a phenotype, what I have observed in our own series is if the sibling or a parent having same kind of an optic nerve head, or the grandparents, what I've seen in at least few of the families I have screened now, you look at the optic nerve head of the right and left eye, if it is kind of a same optic nerve head only is coming up in the families. So if we really look at that, and what I've observed is as far as the eyes, as well as on the systemic illness is concerned, many of the genetic disorders seems to be coming in the same way. But I can only give you an anecdote as of now at this point in time. I've screened grandparents, parents, and the children as of now. So it gives a great indication looking at the optic nerve, not at the NFL level, but RNFL is also teaching quite a lot of lessons to me now. So it's quite interesting to see the optic nerve head in a good SLO fundus photography and correlating this with the phenotyping. And even the time periods also, what I've observed is, say, for example, you have a systemic hypertension or the GI disorders, or also setting up in the children or from the parents what time period that they have had the disease seems to be kind of at the similar kind of a time period it is setting up. So 35 years, a labile hypertension is setting in your children. It seems to be the parents also having the disease at the same period of time, or maybe little plus or minus. But it is quite interesting. But as of now, I have a very early data. But I just thought I will share you this information. Maybe useful, I don't know, but I thought I'll just share you this. Pradeep and Dr. Karim, Jitin, and
Nestle.
Nestle. Sorry, I have a short-term memory loss, so all of you can just give your comments if you have anything on this.
I think I'm going to defer to Jitin and Nasli, because I think maybe they can, with the work on genetics and Jitin's work on multimodal clinical data.
Absolutely,
Really
that's what I was trying to say.
get a
Multimodal
sense
one
of,
is, yeah.
Yeah, how well can we really predict the future? And can we really predict it well enough to have enough confidence that we really alter our treatment? I mean, certainly in some borderline cases, I think it'll help, but can we really be confident enough that we can change our parameters to a great degree or not?
Especially
Yeah.
Jitin's talk on the OCT, the 5 micron change in Zeiss OCT, I felt it is a little less. I think it is up to about 8 microns is the difference in the inter visit or even in the intra visit, the variability of the GCL, because it picks up both GCL as well as the IPL. It is not only picking up the GCL alone. So the variability is pretty high as it is not using the APS. So it's quite high actually. So in that way, again, looking at only the pie chart or the clockwise chart is not going to be really kind of useful as far as I'm concerned. But I look at only the graph and looking at the temporal part of it, especially on the PMB and the PFB, makes a lot of difference actually. Because we see the PMB loss is much more than the superior arc weight or the inferior arc weight loss in the RNFL change in the glaucoma, especially in the NTG or even in the PYAG group. The PMB loss is much, much higher than the superior or the inferior arc weight loss.
Jitin, any
Yeah,
opinion?
so I think it really depends on what your outcome is, right? So for the work that I presented, what we were doing in that model was we were trying to predict future visual field change based on an initial set of visual field, OCT, and clinical data. So I presented some figures that I did it pretty quickly that had AUC values. And if you look at those figures, the AUCs actually were not terrible if you just use the visual field. If you added the OCT to the visual field, it did a slight improvement, but it really is when you added 2 or 3 longitudinal fields over time that the AUC values really improved. So in that case, where our outcome was a visual field-based outcome, where you're looking at the risk of rapid progression, then the visual field was actually quite important, and the OCT didn't matter as much. I'm pretty sure, I'm going to conjecture that and say that if you're looking at an OCT-based outcome, then having multiple OCTs in a row, or at least a baseline OCT, would be most important. And the same goes for fundus photography. So there have been groups. I think NASLI has done some work with the OATS study where they only had access to fundus photos. And I think in that work, the fundus photo was especially important in their modeling. So I think it really depends on the outcome, whether it be visual field progression, OCT progression, fundus photo-based change, or what your definition of glaucoma is, if it's a diagnosis-based project.
Okay.
Yeah.
I want to give the last comments to Dr. Kavita, my colleague, before we close the session. Yeah.
A big thanks to all of you. Lot of learning from the wonderful talks. So I have a quick question to Dr. Nazli. You were showing the graph on the polygenic risk score and the association between the angle closure disease and the patients on the treatment for depression. So why is this particularly you looked at this association? And the second question, just adding to what Dr. Krishnadas said, was trying to discuss, we also saw all the siblings of patients with PACS had more of PACS and not the complicated iridotrabecular contact, that is no PAC, PACG. So we were also thinking of maybe there is some high risk open angle group, which was going and developing primary angle closure disease or primary angle closure glaucoma rather than the PACS group. So any thoughts on this? Have you done any work on that part of it?
Thank you. So I think that is still a very open area of investigation. Unfortunately, we don't have the data to look at that at the moment. But really, that could explain part of the paradox, right? It might not be those PACSIs that are progressing to PAC, PACG. It might be people going from initial open angle or maybe going through a PACS stage very quickly and then going to PAC, PACG. So it's hard to know, but I think for that we need well-designed longitudinal studies. And one thing that a lot of these trials have unfortunately left out has been genetics, and we're understanding more and more that we need to include that to understand the risk of disease better.
Thank you. Thank you, Nazli. I will give the president the closing comments, madam.
You're muted, Sujata. Sujata, unmute.
Thank you, Dr. Venkatesh. It was an excellent learning experience. And till recently, I was practicing glaucoma. Dr. Venkatesh knows about it. And I think to me, it's a little bit intuitive. I look at the social and economic background of the person before I decide whether they need to go for treatment, particularly in patients with PACS. And if I feel that they may not come for a follow-up and it's very difficult to convince them, I would rather do a PI immediately. I think I would err on the side where it's safer for the patient. But at the same time, looking at all the other data and also the studies, it's worthwhile holding back. But as a glaucoma specialist, I would base my treatment more on intuitiveness and looking at the patient's profile and decide. And I really enjoyed the talk by Dr. Karim and Dr. Pradeep. And of course, Jitin, I've been doing this cluster OCTs without even realizing that it really makes a value. And so I feel good about it. And we tend to call the patient within a few days, particularly patients who tend to travel abroad or going away. We ask them to come back. And I've always looked at OCT less than even 6 if I am able to get some good data. So it validates what I've been doing. I'm so happy that I could hear this talk from you. And I'd like to thank all the panelists for sharing their time and for this wonderful session. Thank you. I'd like to thank Sai from Numerotech for conducting this webinar. Thank you.
Thank you. Thanks, everyone.
Thank you all again.
Thank you.
I hope, Karim, you will reach.
Thank you so much. Thank you so much, everybody. Thank you.
Thank you, everyone.
Thank you. Bye-bye.